My talk will follow up on the content that Dr. Bégin and Dr. Upton presented, focusing on the evolution of immunotherapy and food allergy, what's really available now or should be available and is only limited by access, and a little bit on the immediate future as well. So my disclosures are there, most relevant being on the OIT guidelines for the CSACI and being on clinical trials for food allergy immunotherapy. The objectives are firstly to review different forms of food immunotherapy. Secondly, examine what food immunotherapy accomplishes and who it's best suited for, and then to discuss what's on the immediate horizon. So we've already heard this morning about the threshold concept. And so basically, if a patient is eaten below that black line, then they're not going to have an allergic reaction. And if they've eaten an amount above that black line, which is the threshold, then they're going to have the allergic reaction. So this analogy of the water level is a good way to, simplistic way to think about this threshold concept. When it comes to OIT, oral immunotherapy, let's discuss some terminology to have a common understanding of the treatment. So OIT is where the food allergen is eaten on a daily basis, starting at a dose below that black line threshold for trigger a reaction. Over time, the dose is increased, typically at intervals of every 2 to 4 weeks, and in between, the dose is eaten daily. And so there's a build-up phase where the patient is going from a much lower dose to a target dose, which is the maintenance dose. And then the maintenance dose is where they're continuing that on a daily basis, usually for about a year in duration, with the build-up phase being roughly, typically about 5 or 6 months duration. So the entire length of time to get to desensitization often is around a year and a half if everything goes well. And a good example of a common maintenance dose is 300 milligram peanut protein or protein. Now, desensitization is the phenomenon of not reacting to the food while being exposed to it regularly. So with OIT, it's daily. And at the end of that, the threshold increases. And we measure that through the oral food challenge, which is what we've heard about so much this morning. That's different from the concept of sustained unresponsiveness, SU, or remission, which is where even after stopping the OIT for weeks or months, there's still no clinical reactivity as measured by the oral food challenge. Now, one step further is tolerance, which is where there's absence of that clinical reactivity, regardless of the length of time since the OIT has been stopped. So the patient could have stopped OIT for years even, and the food allergy reaction does not return. And so that's what Dr. Bégin referred to earlier as the closest we have to a cure. And we have evidence of that happening in infants. And that's where we have disease modification. And that's very, very exciting. And what many of us, describe as an almost an emergency to get treatment started at that very young age bracket. This has been shown already in various ways this morning, but during the time course of OIT, you have the serum immune markers changing. So you have in blue the specific IgE, which initially rises and then comes back down to the level it started at. And then over a prolonged period, it can reach an undetectable level, which is what we, again, would expect with an infant started on OIT, for example. And there in the red line is the specific IgG4, which is a marker of tolerance. What happens during an oral food challenge? So Dr. Upton already went over that, but here's an example of the doses that a patient might ingest during an oral food challenge. So we'll do that as shown in the previous slide at baseline if necessary to confirm the diagnosis. Often we don't have to at baseline if there's a convincing history and positive testing. confirmatory testing. But at exit, we really do want to do this procedure because there's really no better way currently, as we heard, to measure the effectiveness or efficacy of doing OIT. And in children, typically, most of the literature aims for a total goal of 4,000 milligram protein, which is roughly equivalent to 4 teaspoons of peanut butter. So I had the honor of being on a co-lead of the CSACI OIT guidelines along with Dr. Bejan and Dr. Kim. And these are some of the main recommendations from those guidelines that we published in 2020. And we're quite proud of these guidelines because outside of Canada, there are very few OIT guidelines. Many are not aware that to this day, there are still no OIT guidelines in the US. There have been OIT guidelines for Europe, but very few OIT guidelines around the world. So our guidelines establish that OIT can be offered outside of research because prior to 2020, there was still quite a debate as to whether it should be offered in the clinical setting. Secondly, that OIT can be done with non-pharmaceutical food-based products, i.e. grocery store products. So that's quite a contrast with how in the US, there's some investigators and clinicians who feel that there should be an FDA approved product, a prescription product, and that should be the one that OIT should be offered for. But we could find no evidence that prescription products offered any additional benefit when we did a literature search and systematic review. All the recommendations that we had in our guideline were applicable to any food allergen, so not just for peanuts. So much of the literature for OIT is about peanut, and the only FDA-approved product in the US is for peanut when it comes to OIT, but we couldn't find any data to show lack of safety or efficacy for foods beyond peanut. And there's actually also lack of plausibility that the mechanism of OIT would be different for peanut versus other foods. So many of the Canadian allergists practicing OIT outside of research are currently offering it to a variety of foods. Now, just something that continues to need emphasis is that uncontrolled asthma is an absolute contraindication. We cannot start OIT if a patient has uncontrolled asthma. And the way I approach eosinophilic esophagitis or EOE is exactly the same, that if it's uncontrolled, then it's an absolute contraindication. But if it's well controlled and managed, then it's a discussion with the family as to whether or not to proceed with OIT. And in my clinic, we do for controlled EOE. Now, a very seminal study that validated OIT efficacy with high-level evidence was from the AR-101 paper published in the New England Journal of Medicine in 2018 now, so quite a few years ago now. And this study recruited over 500 participants randomized to the peanut OIT at a maintenance dose of 300 milligram protein versus placebo. Most of the participants were in the 4 to 17-year-old age bracket, and that's where the significant results were published. The middle of the left side was the primary outcome of 600 milligram protein eliciting dose, and almost 70% of those in the OIT group were able to achieve that primary outcome compared to hardly any in the placebo group. So this high-level data allowed the FDA in the US to approve the Palforzia, is what it's called, as the peanut OIT prescription product. Now, it's very expensive medication, so it costs in the order of roughly $10,000 per year. And there hasn't been widespread adoption, is my understanding, in the US, partly because of cost, partly because there's a safety reporting mechanism, which is very elaborate. So to this day in the US, there's still pretty widespread adoption of grocery store-based OIT. So what can OIT accomplish? So if the patient is adherent, and that's a really big footnote because sometimes the adherence is less than desired, then it can accomplish desensitization, the term that I had mentioned earlier, increase in threshold. What many families are really seeking is protection from accidental exposures. And again, it can achieve that through desensitization. Improve quality of life and reduce food allergy anxiety. You'll hear more about those concepts later on today. Those are very important outcomes for families when it comes to OIT, and it can accomplish that with good adherence. And again, we, through grocery store food products, the approach that we use in Canada, can treat with OIT almost any food allergen, which is really a big advantage of that approach. What OIT cannot accomplish is this holy grail of SU is very difficult to achieve in even toddlers, older children, and adolescents and adults. A very pivotal clinical trial called the IMPACT trial in the US showed quite a difference in SU outcomes according to age brackets, which were not that big of a difference. So from 12 to 23 months, that's where the SU was impressively high, over 70%. But as soon as you went to a slightly older age bracket of between 24 to 36 months, then already you saw a decline cut in half of the rate of SU, which is why, again, so many of us since that study have felt that the infant age group is where OIT is the most important to start soon. What OIT cannot accomplish, again, is that if you're using prescription products, such as the FDA-approved Palforzia, you can only treat peanut, and you can't treat any other allergens, and that's a big limitation there. Now, Food Allergy Canada did a survey last year of their members on how satisfied they were with OIT, and as you can see, they were really satisfied. So 74% were very satisfied, and 24% were somewhat satisfied. And the profile of the respondents predominantly were parents of children with food allergy. And in terms of the quality of life data, there have been many publications on this, some of them with mixed results, but the ones where they tend to follow the patients for longer throughout the journey, throughout buildup, maintenance, and follow-up, do show improvement in quality of life. And we have both prospective cohort data to look at, as well as clinical trial data. So that's been another benefit of having high-level clinical trial data, that they can have large numbers of participants followed for long-term, both during the blinded phase as well as the open label phase. And you can see on the right-hand side, general improvement in quality of life. There was just not the significance seen for the very youngest age group, which the investigators there attributed to fatigue on the part of the parents of those younger children participating in the clinical trials. What's on the horizon for OIT? So Dr. Bejan talked about biologics, omalizumab, and what's a bit, I would say, to me as an allergist interested in immunotherapy, a bit disappointing about the FDA approval indication for omalizumab is it's only for monotherapy, not combined with OIT. So, that restricts it then to the application of where once the patient, if they were to go off of that treatment, then the food allergy would return. So there's no disease modification potential. In terms of combining OIT with something like omalizumab, hopefully there will be that prospect in the future. But again, these medications are not approved for food allergy in Canada, and it would be costly. So then that's why the OIT hopefully would overall reduce the cost, because at some point you could stop the omalizumab and then the OIT would provide the potential for disease modification. There is a Food Allergy Canada webinar focused on omalizumab following the FDA approval for monotherapy. And so you can look through the website for that. What's also on the horizon, Dr. Upton is leading work at Sick Kids looking at lower maintenance doses for peanut and tree nut OIT. And then at McMaster, there's work underway comparing sublingual immunotherapy with tree nuts to low doses of OIT. The adult OIT requires a lot more investigation. So just on the news in the past few weeks, there was a paper published out of the UK, which actually only had 20-something adult participants in that clinical trial. And it showed decent efficacy and safety, similar to the older children, adolescent data, but it's a paucity of data. And so it's, the Palforzia even was not approved for adult patients. And so we just really need more options for adults. Now, then on the flip side, then who is OIT best suited for? Well, really, it's best suited for infants and preschoolers when you look at the OIT literature. And we can also look at, for safety, data such as emergency room presentations for anaphylaxis. And I showed this in a talk that I did yesterday for family physicians. When you look at data where there's hundreds or thousands of patients presenting to the emergency room and compare their symptoms when they have anaphylaxis, the infants less than 12 months tend to have milder reactions. So they have predominantly skin and gastrointestinal based reactions when it comes to anaphylaxis. Whereas for the older children, then you get into the upper and lower respiratory symptoms for anaphylaxis. And that helps to explain why, when we do OIT in infants and preschoolers, we tend to see a very low risk of severe reaction in the order of between 0 to 0.7%. And that's both from clinical trials as well as real-world studies. And again, from the IMPACT trial, much higher chance of SU in infants. And so, predominantly it's from a safety lens, but now it's also from an efficacy lens for why it's best suited for infants and preschoolers. And then we have data that's been published through systematic reviews and other studies that, the chance of a severe reaction for an older child and adolescent, it depends on your perspective of whether roughly 15% chance is high or acceptable. But it's quite a contrast in any event with the infants and the preschoolers. And although we need more accurate data, there is a roughly 2.7% risk of triggering EOE from OIT in older children and adolescents, and that appears to be much lower in infants and preschoolers. There's an absolute contraindication, again, for patients with uncontrolled asthma, and there's an increased risk of reaction with cofactors, which applies to all patients on OIT. So with this evidence that OIT is safest and most effective in infants and preschoolers, we approached the Canadian Medical Association Journal last year, and they have an article series called 5 Things to Know, which makes it really easier to absorb for busy primary care clinicians what the essential clinical pearls are of a topic in medicine. And so the 5 things to know for OIT, the editors of the journal were really interested in infants and preschoolers, so that's where we focused. And so simply, OIT is a treatment option for infants and preschoolers as an alternative to food avoidance. The allergen is administered in increasing doses. The evidence favors infants and preschoolers. OIT reduces the risk of reaction due to accidental allergen exposure. And most exciting, early initiation of OIT is disease modifying. So, just a little bit on how my OIT practice has evolved over the years. So I was doing OIT only within research until roughly 2017, and then started offering it outside of research just before publication of our OIT guidelines. But it's really evolved even since 2017. So initially I was doing build-up visits in clinic, typical build-up schedule, 11 build-up visits for an allergen. Initially, I was even doing 11 buildups for one allergen like peanut, and then another 11 for another allergen like cashew, total of 22 buildup visits. But very quickly realized this was completely unsustainable for our clinic. We didn't have the physical space. We have a almost 2-year waiting list for routine patients. And so it would have overwhelmed the clinic. And so as our practice evolved, we started offering build-ups virtually. And that happened around the time of COVID, and that was a silver lining of the virtual platform. But then even that became a challenge in terms of the appointments, because that helped to address the physical space. And so what we've now evolved to is home-based escalations, where sometimes we'll do the first dose or two virtually supervised, but even now some of the families through shared decision-making who are comfortable doing the first dose on their own at home are doing that. And what I'm doing is scheduling periodic follow-ups virtually to check on their progress. So maybe that would be every 1 or 2 months initially, and then gradually lengthening. And so these sort of novel approaches are supported by the evidence that I showed that the risk of reaction in an infant or preschooler is very low for severe reaction. And the virtual option alleviates the office space concern. The home-based option reduces demand on the clinic wait list and allows the allergist to see other patients with those very precious in-person appointments, and allows them to save those appointment slots for the less common scenario, for example, of an infant with a severe phenotype where you can offer more of the supervised approaches. So there's emerging evidence for these approaches, and really, why is that? Because Dr. Bijan mentioned it's impossible for our workforce and allergists in Canada and around the world to meet the demand for OIT. So we need more evidence like this really to support easier access. And hopefully in the next decade or so, it'll be much easier for families to access OIT than it is at present. So with OIT discussed, let's look briefly at other forms of food immunotherapy. So what is sublingual immunotherapy, or SLIT? That's where the food allergen is placed under the tongue daily. There's rich mucosa there, and there's variability in length and degree of buildup, but there still is a bit of a buildup, and it's followed by maintenance dosing. And the maintenance dose, the key takeaway is it's a fraction of the maintenance dose of OIT. So the published maintenance doses typically run between 2 to 4 milligram protein daily. So that's like typically similar to the starting dose of OIT. And so, it's like, it can be like less than 1% of the dose of maintenance dose of OIT. Because the maintenance dose is so low and the area where it's administered, it's very, very safe, like essentially negligible risk of a severe reaction. And therefore, it's best suited, based on my earlier comments about older children, adolescents, and adults, it's best suited for that age group. It's also best suited for them because it's hard for an infant or a toddler, harder for them to place the dose under the tongue for 1 minute. But it could be used for toddlers who have failed OIT because they have had severe reactions. There's also, because of this safety, much less concern about cofactors. So what can SLIT accomplish? It can also accomplish desensitization. The ability for it to do that is actually better than what used to be thought with the newer evidence. So it's kind of like, quote unquote, slower and safer than OIT. It can, because it can increase threshold, it can protect from accidental exposures, improve quality of life, reduce food allergy anxiety, just like OIT can. And if using grocery store food products, which is a novel application of it, it can treat any allergen, just like OIT. SU, again, less likely in older children. There's thoughts that it can be achieved if you're starting it very, very early, such as the toddlers, but more research is needed. Where we have chosen at our site, our center, to apply SLIT is we at first tried to obtain the skin test extracts for treating with SLIT, just like they do in the United States. But in Canada, we were unable to get access to that. And so we went back to the drawing board and decided to develop grocery store-based recipes. We have just published those recipes in the past couple of months, and we published protein quantification studies of those grocery store recipes. And the methodology we chose was doing 1 to 2 years of SLIT and then bring the children in for the gold standard procedure of a food challenge to see if their threshold increased not to 4,000 milligram protein, but to 3 milligram protein. The reason we chose that was we looked at some of the longer term SLIT studies out of the US, and the majority of patients seem to be able to achieve roughly 250 milligram protein after a few years. And so we chose that as a way to assess the effectiveness of the grocery store product, but also as a launch pad to start the OIT at maintenance dosing, so they wouldn't have to, the families wouldn't have to fiddle with the intricate buildup process of OIT. And so the top part shows again that journey of where they're doing the SLIT buildup for 2 to 4 months, SLIT maintenance for 1 to 2 years, flipping during an oral challenge to OIT, and then doing the OIT maintenance for 1 to 2 years. Right now, we're starting to do more of the purple assessments, and so stay tuned for the outcomes of that. But with this paper we published last year, we had 188 higher risk patients. So these were patients who had a history of severe reactions, high specific IgE, and knowing that those are not accurate predictors of severity, but at least the age, as Dr. Upton was suggesting, was somewhat of a predictor of severity, and none had grade 4 severe reactions. And those who underwent the light blue box, 70% passed that challenge, allowing them to skip OIT maintenance, OIT buildup. Now, of course, there's other ways to use the SLIT. Maybe you can do the SLIT and then do a full OIT buildup schedule, but this is just the way we chose to study it. And so what's on the horizon? It's not like we're so fond of the grocery store that we don't desire other options. So right now there's research clinical trial underway for peanut SLIT tablet. That would be wonderful because that would save the families a lot of time for preparation when it comes to these grocery store options. And this website shows the sites in Canada that are doing this clinical trial. So there's 9 sites there listed there. Then just a few moments on the epicutaneous immunotherapy, the so-called peanut patch. So this is a patch that's applied on the back. It starts at 6 hours per day, but then quickly goes to 24 hours per day. And the maintenance dose for that is much lower even than SLIT. So it's only 0.25 milligram peanut protein. And the safety and the efficacy, although there's no head-to-head comparison with OIT and SLIT, from the literature, we should estimate it to be similar to SLIT. So kind of like a safer and slower option than OIT. And so this is another option. It's good to have more options, and some patients may have a preference for this over the OIT and the SLIT. And so very similar what it can and cannot accomplish when compared to SLIT. It has not been approved by the FDA or Health Canada yet. It's undergone clinical trials for many years, since roughly 2016 and even before. And just in this spring, there's been an agreement with the FDA from the company developing the product to accelerate the timeline for a biologic license application filing for the peanut patch. And so to summarize the comparison of these modalities with avoidance, avoidance is still an option, and it's best suited for older children with very few accidental exposures and good quality of life, as Dr. Bejan had described. The OIT ideal for infants and preschoolers, and then the SLIT would be for older children, adolescents, and adults. But of course, these can be applied to many age groups. We can get protection from accidental exposures. We can treat any food when it comes to OIT and SLIT. EPIT would be mainly peanut once it's approved. And SU is challenging except for infants for OIT and SLIT. The current landscape, so roughly in a survey we did a few years ago, roughly 50% of Canadian allergists are offering OIT outside research using grocery store products. SLIT, because this grocery store modality is very new. Very few allergists are currently offering it outside of our center, but the hope is that more will start offering it with publication of those results. And I talked earlier about what's on the horizon. And then some key considerations would be, essential to control the asthma, referral to allergist who offers these therapies, within research, outside research, both possible. Food allergy diagnosis, as we heard from Dr. Upton, essential to have accurate diagnosis before initiating food immunotherapy. And the build-up process, I went over the cofactors we've heard all morning, and then typically follow-up assessments during build-up and maintenance, but really essential to expect and exit oral food challenge to assess the threshold increase. And so take-home messages are different forms of food immunotherapy each have unique characteristics with respect to safety, effectiveness, and practicality, and that the specific choice of food immunotherapy for a family should be personalized based on patient age, baseline severity, risk, family preference, using a shared decision-making approach. So, often personalized medicine is, thought of based on genetic testing and precision medicine, as we heard from Dr. Caulfield earlier. But, we do have enough tools in our toolbox even today to have some degree of personalization based on these variables. So with that, thank you. And now we have some Q&A.